but I serve on the board of directors of the American Society of Addiction Medicine, and my role is as the committee chair for the Physician and Training Committee. I say this because it's so important that we are all getting educated around addiction medicine. My job has been since 2018 on this committee, as chair of this committee, to bring addiction medicine resources into the medical school classroom, and begin a process of properly educating our young minds that are becoming physicians in addiction medicine. And we've pretty much got an entire buy-in at every medical school across the country and primary care residencies as well. So if we don't train young minds, we will never get out of the crisis we're in. And that's the point of what we're doing today, educating folks on addiction. So just before I launch into my marijuana slides, I just want to give everyone sort of an overview of what we understand now to be the vulnerability of addiction. So we understand that genetics is about 50% of the entire proposition for addiction. So 50% of addiction comes from certain genes. We are now able to isolate those genes. I am told by the FDA that the genetic product that I helped co-create is going to be given emergency use authorization. We have 15 single nucleotide polymorphisms in the nucleus accumbens that we've identified, and we can now predict who's going to have a fully codified opioid use disorder if they're given a prescription for opioid analgesics. It's 88% positivity value and a 97% negativity value. So genetics is going to really blow our field open and really give us some agency when we're talking to patients and families. So genetics are 50% of the proposition. The environment represents the rest of the proposition. So you all are familiar with the adverse childhood experiences studies, and we know that if someone's had 4 or more adverse childhood experiences in their youth, that they have a 7 times greater risk to go on to manifest the disease of addiction. Also, how you take the drug, and more importantly, when you use the drug, which is pertinent and salient to this discussion. We used to think the brain was fully mature at the age of 16. We now know that for women, the brain matures around the age of 23. And for men, most women would say never, but it's actually at the age of 26. If you use before the age of 15, you have a 4 times greater risk of going on to manifest the disease of addiction than someone who waits until they're 21. And that risk is independent of genetics. The brain mechanisms that are involved, we know them now. The 2 most important areas of the brain are the ventral tegmental area to the nucleus accumbens. That's a reward center. That's where marijuana and every other drug increases dopamine. And then the prefrontal cortex goes offline when someone's in active addiction. So the more primitive part of the brain is active, and the more sophisticated part of the brain is inactive in the commission of active addiction. So that just frames what I'm trying to talk about, because it's so important to understand the inroads we've made through studies looking at the disease of addiction. And it is a chronic brain disease. It's not a moral failing. It's not a lack of willpower. It's a chronic brain disease. So we need to look at history so we absolutely don't repeat it, right? So we're going to look at historical trends and see just where we're headed right now. So this is just looking at, a Pew Research Center poll, and it's the U.S. Public Opinion poll on legalizing marijuana. And you can see here that the shift has occurred somewhere around 2010. You started to see a dramatic shift in people's opinions of whether we should legalize marijuana. And that occurred because we began to allow states to legalize medical marijuana. And by doing so, that was an entree to complete legalization, recreational legalization as well. And you could see that there's been a flip-flop over time that happened really very recently. And then you just look at demographics, you can see the majority say that marijuana should be legal. So this is, this stems from the fact that we've been living with medical marijuana. And when you say that a substance is safe and medicinal, it's not a leap of faith to believe that it will be completely legal across the country at some point in time. And that is indeed what's happening. And this is just looking at historical trends. So if you look at these numbers here, well into the 60s, even to the 70s, and then you look at these trends here back in 2014, the numbers were less, but we've seen a steady increase in opinions in favor of legalizing marijuana. And then this is just looking at the different generations. So I'm a baby boomer, I'll just say that. And my parents are in the silent generation, although I've never thought of them as silent. But you could see the other generations are very much in favor of making marijuana completely legal. So millennials, Gen X's, my generation, boomers, the only one that's the holdout is my parents' generation. And the reason for that is that they've always been told that marijuana was a poison and dangerous. And we, from boomers on up, have been told it's medicinal, that it's safe, that it helps people. And there's the shift for you. That's a dramatic illustration of what a campaign can do to make people think that a substance is indeed safe. And when that happens, it's not a leap of faith that it'll become completely legal. And this is just looking at different age groups. And really, you could see that all age groups, even those that are in my parents' generation, are thinking that it should be medically legal at least. And then a great majority in all majority, I should say, in all the demographics for the most part, are saying that it should be both medical and recreationally legal. So this is a shift of thinking, and it's been quite the campaign to get to this point. But you can see this data is fresh in 2022. Back in October, this came about in the Pew Research study. So you can see that folks are really, at this point, in a majority saying it should be legal medically and it should be legal recreationally. And then this is just looking at those that smoke marijuana on a near daily use. And we're just comparing now college versus non-college. And 1 in 9 non-college respondents report daily or near daily use of marijuana. Again, when you think a substance is safe and it can help your mental health issues, then you're going to be using it on a more regular basis. And you can see non-college compared to college students. And that dichotomy exists throughout many of these studies that were done by NIDA and Sampson. And this is just looking at trends. You could see that we have been sort of flat for a little while, and there's been a steady increase occurred from 2014 on. And then this is just looking at the most vulnerable of us, 8th graders, 10th graders, and 12th graders. And you can see that there has been a significant amount of them using marijuana, in those grades. And you could see that in the study here with 12th graders, there actually was a little bit of a decline. If you contrast this with cigarette smoking, we've done a really good job of making sure young people understand that cigarette smoking is not safe. And as a result, when monitoring the future studies, that what they show is a decrement year in, year out around cigarette smoking. And the same, unfortunately, is not true when it comes to using marijuana in whatever form. And then this is looking at vaping. And this is, again, the monitoring the future study. And you can see that there's been a pretty dramatic increase in both college and non-college. And what we're seeing is that vaping marijuana products have increased steadily over the years. And it's something that, we've had to control in treatment because folks want to have the right to vape. But what's happening is they're vaping marijuana products in treatment. And that's something that we've had to control both at Karen and since I've been here at Brookdale as well. And then this is just looking at a steady increase data up to 2021. And you can see clearly here that marijuana use is on the uptick over the last 10 years. And so is hallucinogen use, which is interesting. That's mushrooms. And again, here's why. Psilocybin has been in the news as a really important treatment for depression. Those studies that are being done in Hopkins, I'm very familiar with. Dr. Eric Strain's in charge of those studies. He's a dear friend of mine. And it's not ready for prime time. However, there are companies out there and practices that are using psilocybin and microdosing to treat quote unquote depression. So that's given the public an idea that this is not only safe, but medicinal. Same is true with ketamine. We're seeing a rise in street ketamine use because ketamine now has been approved by the FDA for recalcitrant and refractory depression. And again, that message is not so subtle. That message is saying that this is medicinal, it's helpful, it's safe. And they're using it on their own, buying it from the street, which is not the product the FDA approved. So as we get into these alternate forms of treatment for depression, so too will we see an uptick in those substances, and we're seeing it here. From 2019 to 2021, there's been a significant uptick and a steady uptick since 2011 when the studies were being done. So let's see what research tells us. And this research is just looking at alcohol, cocaine, and marijuana. And basically the amount of THC in cannabis has risen sharply in the last 30 years. I have other slides that aren't as old to really go into that. So I'm going to jump into that. This is looking at the physical and psychological toll that happens with marijuana use. I'll get into greater detail later, but this particular study is just looking at 12-month physical illness visits. And you just concentrate on the purple line. You can see that the purple line of young people that are persistently using in a heavy way, or even the rust-colored line, those are using in a moderate fashion. Their physical health and their psychological health is being impacted. And then when you look at alcohol and lifetime alcohol problem because of smoking marijuana in a significant way, there's a significant increase in alcohol as it tags along with marijuana. And then when you look at just in general lifetime drug problem, you see a significant increase in the purple line specifically, which are persistent daily users in heavy amounts. And they do tend to grab onto other substances as well. So when people come into treatment, they certainly have a cannabis use disorder that helps bring them into treatment. Often they have other comorbid substance use disorders, whether they be cocaine, methamphetamine, which is on the rise, or they have an opioid problem, which now is all fentanyl. And then this is looking at some of the genetics. So the COMT gene is the catechol O-methyltransferase gene. And this is looking at the effects if someone is using at a young age. I told you earlier that the younger you use marijuana, or any substance for that matter, the greater the risk that you will go on to manifest a true substance use disorder. So you could see in the green, these are folks that were introduced to marijuana during their adolescence. They used it in their adolescence. So what's happening here is the COMT genotype is evolving. It is absolutely being, making people vulnerable to increased use, or I'm sorry, to increase psychotic illnesses. On the y-axis here you see schizophreniform. What that is schizophrenic symptoms that are present for the first 6 months. You can't make a schizophrenia diagnosis until 6 months has passed. And oftentimes what this is substance-induced psychosis or schizophreniform disorder, but it can lead to actual schizophrenia. The data suggests there will be a substantial decrease in schizophrenia diagnoses if marijuana were not being used at a young age. So that's a staggering statement on my part, but it is sadly true. So if you start using at a young age, you will manifest psychotic symptoms and perhaps even go on to manifest true schizophrenia-like symptoms. This is looking at specific genes. So not just in adolescents, this is anyone right now. And you can see that the lighter green, when you use cannabis every day and you have this particular gene, the AKT1 homozygous CC gene, your chances of having a psychotic event are astronomically greater. So there are genetics that really position people to have psychotic symptoms if they're smoking on a daily basis. The point is that while marijuana is being touted as a medicinal tool, if someone has the wrong gene, so to speak, then they will go on to have a psychotic transformation. They'll have psychotic symptoms. We see that every day. I saw it at Karen every day, and I see it here every day. These are folks at different ages that begin smoking marijuana or using marijuana medicinally every day. Because remember, medicinal means every day. And what's happening is that they're having this psychotic transformation. And we're having to give them antipsychotics to get them through that period and hope that the psychotic symptoms are not persistent. And this is just looking at, it's not just a US problem, it's a world problem. So I'll let you look at that slide after the talk because it's a little busy, but you can see that daily use of marijuana is on the upswing. So let's just talk about, marijuana, my marijuana versus today's marijuana. I was going to say my parents, but I don't believe that they used marijuana. I did, but they did not. And it's just looking way back when it was considered a poison. So you see that that tincture there. People understood cannabis to be dangerous, very dangerous. And it was grown for other reasons, for agricultural reasons, actually. And now we see all these different names. These on the right, this is at a dispensary. So if you have a medical marijuana card, you're going to have access to these different substances. There's another slide that you can clearly see the names of it. But when you think about medicine, you think about getting a prescription from a physician, going to a retail pharmacy, getting it filled, and taking it as directed. That's not what happens with marijuana. The doctor who is able to give marijuana cards simply gives you a card. And there's a myriad of symptoms and even disorders that allow for that card to be given. There's no oversight really on that. And then someone goes to a dispensary, there should be a pharmacist or a physician or a mid-level practitioner there. Oftentimes there's not on the premises at least. And you're getting their best guess of what the right blend is for you from a medicinal point of view. Typically that's in liquid form or edible form, but there's an ever increasing way that you can consume marijuana in this country right now, whether it be for medicinal purposes or not. So this is just looking at how much THC, which is the Delta-9 THC, is the active ingredient in marijuana. And there's been a steady increase over time. Also CBD, which is legal. You can purchase it over the internet. There's THC in every one of those products. I am a FAA physician, so I do evaluations for the FAA on pilots, and pilots that have gone to or gotten CBD over the counter, they pop positive on random drug screens for THC, and they're incredulous. They swear up and down that all they got was CBD, which probably is true. But there really are no CBD companies that right now are not putting some measurable amount of Delta 9 THC, tetrahydrocannabinol, which is the active or psychoactive component of marijuana. So these are the different concentrates that are out there: shatter, wax, crumble, butter, and oil. So these are high concentration of Delta 9 tetrahydrocannabinol, which is the psychoactive substance in marijuana. And these are, I'll show you the percentage in just a second, but it's important that you know the street terms for this, because this is what patients are going to tell you, and you really need to understand, what does that even mean? What does butter mean? First time I heard it, I was thinking, a stick of butter, but it's a high concentration THC product. So just looking at this, so the dried flower, it used to be back when I was young, 6%. Now we're up to 30% for smokables. So the dried flower, the percentage of THC is up to 30%. Shatter, butter, and crumble, which I showed you, 80% THC. Live resin, almost 100%. And then distillate, which is what you will use in tincture form, or what you can vape, is up to 90% as well. And an important point on edibles. Edibles have anywhere from 5 to 10 milligrams of THC in them. But the thing about edibles is, if you're looking for an immediate response, say you've been prescribed this, if you will, for anxiety, and your anxiety is through the roof, and you take your edible and you're hoping that it has a Xanax or Valium-like response, it will never do that. It takes 1 hour for the oral form of tetrahydrocannabinol to get into the system and begin its effect. So what we see is that folks are eating these edibles, wanting the response to happen quicker. And when it hits them, they actually have a psychomimetic transformation. So they actually experience very strong symptoms, and could be psychotic symptoms. Their anxiety is off the roof, that which they were trying to treat, because the active ingredient is so high, because you've taken so many of these edibles. So, gummy bears, or if you want dummy bears, if you eat them one after another, it'll have a delayed effect. You will light the fuse, and then the bomb goes off an hour or two later, and then you may very well end up in an emergency room because you're not making sense. And then this is just looking at the differences, way back when, in the 60s and 70s, when I was a kid. It was actually only 1%, and went up to 3% in the 80s and 90s. The average level today is 13%, like I showed you, up to 30%. Concentrates are much higher, 80+%. And then edibles I mentioned as well. So, this is a busy slide. It's just looking at states, and states regulate this. I guess the important part of this slide is that we are a nation of states, and every state has their own rules when it comes to marijuana, medical marijuana, and recreational marijuana. And every state has a different percentage of THC in their products that they allow people to use. So this is just another example. I'll let you look at these slides. You will get a PDF version of these slides, so you can take a deeper dive into all of this. And then, what are the risks of vaping? So vaping has the resin in it, or the concentrate or distillates in it. And what you can see here is this is very, very high potency. Right now, vaping, you can combine all kinds of different products. It's easy to get online, and you're basically using in plain sight, so to speak. So people are thinking you're using tobacco, but you're not. You're using hashish oil or something of that sort, which is high potency, and it's creating, very serious psychotomimetic symptoms or psychological symptoms. Because marijuana, while in lower doses, may be helpful for anxiety and depression, on a daily basis at high doses of THC will increase both of those things. So you're not helping yourself, you're hurting yourself. And this is just the different names. So if you go to a dispensary, this is what they're going to give you. It's blue haze, it's not a milligram dosage. There's no frequency how to take it. There's even no, it's just these interesting names, and that's what the dispenser is going to suggest, given the card and the reason you're coming to the dispensary. So let's talk a little bit about some of the symptoms associated with marijuana, and these are related signs and symptoms of cannabis. So there is a withdrawal syndrome associated with cannabis. Oftentimes that looks like persistent nausea and sometimes vomiting associated with that. We often see patients that come in scalding their skin to reduce the nausea associated with the marijuana withdrawal syndrome. There's a rebound in anxiety and even in depression. There's a shakiness that people report. And then these are all greater risk factors for addiction, because what happens is people don't want to tolerate this withdrawal syndrome, which is quote unquote mild, when compared to other withdrawal syndromes. However, it may lead to use of other substances, benzodiazepines, opioids, or some other substance, just to reduce some of these withdrawal symptoms from cannabis. And then this is just looking at protective factors that may reduce the risk for marijuana cannabis use disorder. So if someone has a positive temperament or belongs to even though they belong to a vulnerable group, or social and cultural factors or interpersonal factors and individual risk factors are there, that's protective. Intellectual ability, so cognitive reserves are indeed protective. I've been working with healthcare professionals for a lot of years, and their cognitive reserve is such that it takes them a little longer, a greater glide path, if you will, of use before they come in for treatment, because they have those large cognitive reserves and they're able to function until they're not. Having a positive and supportive family, social support system, caring relationship with at least one adult, and education and employment training. So all of these things are things we work at in treatment. We're trying to replicate whatever we can replicate. Obviously, intellectual ability, education is something that's kicked down the path. But if we can somehow get folks into good, positive social supports like AA, NA, and then also, engage the family to be very supportive when they get out of here. So this is the DSM-5 criteria for cannabis. So these are the different disorder questionnaires that we employ when people come into treatment. So these are very similar to the ones you guys are all used to, I'm sure. And so I won't bore you with all of that. I mean, this is the same for any substance. There is a withdrawal associated with cannabis. There's certainly a tolerance, meaning that they will have to use more and more for the desired effect. It is impairing. If you're on medical marijuana and you're driving and you get into an accident, you will be given a DWI. And then this is just looking at the DSM diagnoses. And it's just looking at specific signs and symptoms that come about with marijuana use. So irritability, anger, aggression, nervousness or anxiety, sleep difficulty, decreased appetite, weight loss, restlessness, depressed mood. So these are all the things that we're looking at specific to marijuana use. And you can see that these are all interconnected. And it's really, the thing I can't stress enough is that the use of marijuana, whether it be medically or recreationally, will not improve your mental health in the long run. It will actually, you will start to see a decrement in your mental health if you're using on a daily basis and needing to use more and more to get the desired effect because of the potency. And when you switch over to different high potency products of cannabis, you're going to have even greater mental health issues. And this is just looking at some of the studies that have been done. This is just cannabis health effects. So we like to think that cannabis is medicinal, but these are real-time health effects that all of us can experience because if you're using either vape or you're smoking the flower, you may get breathing problems. It will cause vasoconstriction of the bronchial tree. 50% of folks that use have an increase in heart rate. If you have a coronary artery disease, that could be a failed stress test. I've seen patients that use marijuana and high potency products whose heart rate elevates dramatically, and then they have a myocardial infarction. If you use at a young age, there's certainly child development problems, and certainly there is teratogenicity if used in pregnancy. And then intense nausea and vomiting can happen in withdrawal or can happen in some people when using. And this is all the withdrawal symptoms listed out very nicely. The common ones that we see is irritability, exacerbation of depression and anxiety, nausea, then vomiting, but all these other symptoms can be present as well and need to be managed. I mean, we've long understood in the insurance world that there is no such thing as cannabis withdrawal and that we can't detox them from cannabis. But it's important that we use comfort medications to try to reduce some of the burden that you see here. And there is indeed a science to all of this and a need to manage the withdrawal symptoms. This is a famous study I'm sure you guys are familiar with. Early use of marijuana increases the likelihood of later drug problems. I illustrated that in the prior slides. So I just, I ask you to take a look at this study in its totality. But according to NIDA, 1 in 6 individuals who begin using marijuana as a teenager become addicted to it. So that's a pretty significant number there. So the younger you use, as I said before, the greater your risk of manifesting the disease of addiction, and in this case, cannabis use disorder. And this is the New Zealand study that looked at heavy users of marijuana, and you saw imaging studies that showed white matter infarcts, white matter abnormalities as well, and especially in those who started early. So again, 15, sort of that magical age, 15 or younger. If you start using on a regular basis, you're going to have damage to your brain. And in this particular study, they saw a decrease in IQ points that ended up being permanent of six IQ points. So just looking at treatment factors and trends, CBT, contingency management, motivational enhancement therapy have all been used successfully in cannabis use disorder. And so this is on the counseling side of things here at Brookdale, and when I was at Karen as well. From a medical point, we're just managing some of those withdrawal symptoms and dealing with some of the lasting psychological issues that come about and treating them while they're in treatment. So there are medications we can use to help them for what ails them, but the real heavy lifting is done by counseling using CBT, contingency management, and motivational enhancement treatment. And then again, in addition, so happy that I'm being able to present be part of the conversation. They do amazing work. So support groups, community support is so important. It plays, an important role helping people throughout the whole recovery process, period. And 12-step facilitation therapy, AA, NA, are so important to establishing a fellowship of recovering men and women that you can rely upon, getting into a healthy group from an unhealthy one where there's a tremendous amount of peer pressure to use. It's designed to increase your motivation. And it's often, something that people resist early on, but once they do capitulate to the need to establish themselves in a 12-step program, they find that they have tremendous support from everyone in that program. And again, this is just looking at the comorbid mental health issues, and we need to have concurrent treatment, and that's not just psychopharmacologically, as you see down here, but it's also those treatment strategies I mentioned as well. So, it's a blend of both. We work hand in glove here at Brookdale. We did also at Karen. Our counseling staff, psychology staff, and the medical staff are all, one big team trying to meet the patient where they're at and deal with some of the emergent issues that come about from their substance use. And in marijuana, that can be significant withdrawal, as I listed earlier, or comorbid mental health issues that may not be present if they weren't smoking or using marijuana. So that's all I have. I'll stick around for Lizzie's presentation and answer any questions at the end of that. So thank you.
Thank you so much, Dr. Garbely. Great information. So I think before we jump into Lizzie's, and I know she's got some terrific information to share as well, any questions specifically for Dr. Garbely? And Joe, if you wouldn't mind, stop sharing your screen. That way we can see anybody who wants to jump in with a question.
There you go.
Don't forget to unmute yourself if you want to ask Dr. Garbely a question.
There was one question in the chat. I don't know if you would have the answer, Joe. Are there any states with strict regulations for medical marijuana? Is there monitoring doses or refill periods? Not sure if you know that information.
Colorado and California were, the first out of the gate, basically. And, in order to be the first, you had to, capitulate to the will of your governing body there. So there were stricter rules at the onset of that, but they have sort of dissipated over time. And so the Western states, have been out in front of this for so long. But I think that there's been a laxity when it comes to regulation, and the enforcement's the issue. So there may be laws in the books, but the enforcement has really not been there. And that's led to increased motor vehicle deaths and increased DWIs on marijuana, difficulty finding workers in states because of the DOT urine drug screen that's necessary for folks to work at any profession. So it's been a challenge. I think we, put the cart a little bit before the horse and had, a not so orchestrated rollout of medical marijuana and now recreational marijuana.
And not just mention too, we have a program that hasn't been scheduled yet. We're working on a date with our presenter, but it's called Taking the Lead, and that'll be happening probably in April. We're going to have Jillian Schauer, who is the director of CANRA, which is the National Cannabis Regulation Agency, that she does an amazing job of explaining all the different policies that different states have, kind of a best practices. So Pennsylvania has actually joined CANRA, and most states that have any kind of legalization have participated in that. So keep an eye on that. It's called Taking the Lead. It's once again part of this youth marijuana prevention project, where we'll educate a lot of elected officials and other leaders in the community and throughout the state about kind of, how to manage this, because it is, as Dr. Garbely mentioned, very unwieldy and complex, and every state has a different set of rules. And I'm hearing about caps on THC, limits and things like that have not been effectively rolled out. Is that your understanding as well?
Yeah, they haven't been enforced well, and really, there's a strong lobby It's a multi-billion-dollar business now. So with that, you're going to see less regulation and less enforcement of any regulation.
Exactly. Exactly. And I know that one of the things that we want to address, and I know that Lizzy we will definitely be talking about this as well, but Dr. Garbely, I'd like to know your thoughts about the families, the families of your patients that you're seeing. What kind of challenges have you had, and how have you been able to intervene or support them?
Well, I mean, we involve the families day one, and they come on campus to get educated. One of the things, just specifically to marijuana, that we've noticed is that a lot of the families are using marijuana, whether it be medical marijuana or they're using it recreationally. So they minimize the danger of that, and oftentimes fight for their son or daughter's right to continue using marijuana, even though fentanyl perhaps really brought them into treatment. So that's been a challenge for us to educate folks on that, because they're actively doing that thinking it's safe. I can't stress enough, when we made marijuana medical, and rolled it out, and most states now have medical marijuana laws that allow for it to happen. We've sent a clandestine message, if you will, about the safety of marijuana. So there was, when people feel the substance is safe, you're going to see an uptick in use. If people feel the substance is not safe, you're going to see a decrement in use. And that's true with fentanyl right now. We're trying, I mean, there's no decrement, but we're trying. And people do feel as though fentanyl, might kill their young one. There's no debate there. Even cigarette smoking, we've done a great job reducing cigarette smoking, especially in our youth, because we got the message out that this is not safe. Even if their parents are smoking, they're saying to their kids, don't smoke. With marijuana, they're sharing their marijuana.
Right. Yeah. Yeah, a lot of frustration around this. Thank you so much, Dr. Garbely. Anyone else have a question specifically? And he'll be with us until 12 o'clock, so which we're really grateful for. If not, then I think Lizzy, are you ready to go? Great. Thank you so much. So I'm going to tell you a little bit about Lizzy Lopez. Give me 1 second. Lizzy's an outpatient therapist at Ethos Treatment. She's an experienced clinician who has focused on substance use issues as well as underlying factors that contribute to a person self-medicating. Lizzy also has experience working in primary mental health programs and has a variety of experience with people in different developmental stages, including working with adolescents and young adults. And Lizzy is a frequent flyer with us here at Be a Part of the Conversation. So we're really grateful to have you once again, Lizzy.
Thanks, Kim. Always happy to help, and really grateful to be asked. Dr. Garbely, I appreciate your information. I think he did a really great job of kind of giving you guys some data and some science behind kind of what we're seeing. So I'm going to share my screen. My slides have a lot of information. So as Kim said, they'll be posted. Because this was a CEU event, I was just trying to give you guys as much information as possible. So I'm going to talk about it more from a clinician's perspective. So I've got some data on there too that kind of coincides with what Dr. Garbely was saying, but I'm just going to give you guys some real life examples of some of the challenges that I'm seeing. Specifically with adolescents. So currently right now, I run an adolescent substance use IOP. I also do some young adult work, and I also work with adults though too. So some of these trends I see with the young adults and the adolescents, and the adults, we see it well, as what Dr. Garbely was saying. It's just more with the adults, it's like a primary drug, and then the marijuana is being used in conjunction with that. I would say the difference for me with the adolescent population is the primary drug is the marijuana. So with subsequent use of hallucinogens, so it was really interesting that he said that, because there has been an uptick in hallucinogen use. If you talk to any adolescent that's smoking weed right now, they'll tell you that. So, and it's not just psilocybin, there's acid, that's gained in a lot of popularity lately too. So, when I do my substance use check with clients, I would tell you for the adolescents right now, it's primary marijuana, some alcohol use, and usually some hallucinogen use. And so I just think that's important for you guys to hear, because I do evals almost every day, and I get a parent when I recommend IOP, they're always concerned that there's kids in the group using heroin. That's like always a concern when they're entering treatment. I do not have a single kid in my group that's going on. All of my kids are primary marijuana right now. So to give you an idea, I have 9 kids in IOP, and they're all primary marijuana with subsequent like other stuff, maybe that they've tried, but not consistent use. So I'm going to highlight some of the stuff going on. Let me share my screen real quick. Okay. So can you guys see that?
You're not sharing it, I don't think.
Okay. Get out of here. Share. Okay. So to kind of give you guys an idea of things to consider with the clinician, with the clinical practice of things, as Dr. Garbely pointed out, right, like the THC concentration in marijuana has increased pretty dramatically. So from 2008 to 2017, we've seen an 8% increase. THC is the psychoactive ingredient in marijuana. So that's the thing that's really altering the mood. I would tell you from my experience with the adolescents, like the concentration is even higher because the majority of them are using the concentrates and the oils. They're using that because of ease of access. So I always tell people, like, even back when I was younger and in high school, like the kids that were like lighting up a joint in the bathroom, like they're rebels, you know what I mean? Like they're high risk takers. They're probably going to get caught. Nowadays, you go into any high school bathroom, there's probably a kid in there that has a cartridge, and the cartridge has THC in it, and they can hit it, get high in a school setting. And it's really hard to smell. You'd have to have a trained nose to know. And this is happening sort of at high schools everywhere. So with the THC concentration for the earlier populations, it's even more something to consider because the primary way that they're using it is not the flower and the bud. You do get some kids that don't want to use carts because they understand the risks associated with them. Like they understand, like Dr. Garbely said, that like there could be laced fentanyl in there. They understand that they might not even be getting THC. But because it's ease of access, they can get it on Snapchat. They can get it from the dispensaries from somebody that has a medical card. That is sort of the primary thing that I'm seeing adolescents and young adults use. This is just important to note because when we talk about like substance use, it's sort of like there's like this risk taking that's involved, right? So they're taking risks, and they're greater, and a lot of them know the risks associated, but they want to get high over like consider that like, hey, this thing could be bad for me. This could impact my lungs. And to give you guys sort of an idea, it's this regularly happens to me. So I'll have a kid that's been using THC cartridges, and they think they're using THC cartridges, and I'll drug test them, and they don't even test positive for THC, which means they're just smoking some unknown substances that alter their moods. So they feel like they're getting high, but we don't really know what they're doing. A lot of the adolescents and young adults, they're going to tell you that it really helps with all of these conditions that it's been touted to help for, right? So anxiety, depression. I have a lot of kids that have ADHD, which is a risk factor, right? But they feel like it makes them like normal. And that's like the terminology they've used, right? So they think it helps for all these things that, as Dr. Garbely said, has been in the press that it's beneficial for. And in the state of PA has been given, people can get medical marijuana cards. But honestly, the evidence is pretty minimal in regards to the conditions that THC actually can help. And a lot of it points to more like neuropathic pain stuff, multiple sclerosis. But for adolescents, for the developing brain, the data suggests that there's no known benefits. And in fact, it's just going to make everything worse. So for a lot of my chronic marijuana users that are in that adolescent young adult range, they have chronic depression, they have chronic anxiety, and the habitual use of the substance that they're using for immediate relief is just making the mental health that's underlying worse. I would also say that specifically with the adolescent population, there's a lot of misinformation, just that like the kid is primary mental health and that the marijuana goes unchecked. So I see that all the time with marijuana, where if somebody's using like a harder substance, a quote unquote harder substance, usually the family or the parents are always kind of concerned about the drug use. But specifically with marijuana, sometimes it's really hard to get people on board with an adolescent or young adult that like the marijuana is also problematic while they have the underlying mental health as well. And that's been a huge barrier for me, for educating families, for educating clients. It's like they think this is a mental health problem. And while it is, it's also a substance use issue. Two of the major factors like contributing to what I'm seeing is access and potency. So like I said, the adolescents, the young adults, they're using the more potent forms of THC more regularly, in my opinion, from what I've seen from my clinical practice. And the access is, it's really easy. Like I was telling Kim this when she signed on, like I was talking to a Westchester student the other day and I was working with him because he's starting to smoke marijuana more regularly. And he let me know that at one of the vape shops, you can buy THC cartridges. They don't card, you don't have to have a medical card. And a lot of the Westchester students know that they can go there. So there's a lot of ease of access. So it's not even just like the medical marijuana cards. You can get on Snapchat and, you know, people will tell you that they have cartridges. So it's just, in order to get it, it's not as difficult as I think people would think. And even with the people that have medical cards, they're often buying for their friends, or supplying their friends. So then you get the idea, like Dr. Garbely said, of, well, I'm smoking medical marijuana. It's not my medical marijuana, but it's safe because it's medical marijuana, which is just not the case, right? So what I'm seeing is just, and with the increased potency, there's higher risk for addiction and there's higher risk for severe mental health disorders. I would also say, like, if you've been in the news and seen any of the press, we're in a mental health crisis, especially for adolescents. So not only are we seeing this like uptick in cannabis use, we're also seeing this uptick in like suicide, depression, anxiety, all of these things. So they're kind of coinciding to create like this perfect storm. Of course, that's like a lot of the pandemic, like ripple effect, especially for the adolescents. But all of these contributing factors are just making it really difficult at this time. And the acuity, if you talk to any adolescent provider right now, they will tell you this, the acuity is really high. So like I used to be in adolescent care 6 years ago. What we're seeing in an IOP level of care is radically different 6 years ago than now, right? And what they're seeing in a PHP level of care is radically different. And that just goes to show you that everything is kind of upticked with symptoms and with severity. Some things that I'm seeing that like this can get some attention, right? And I'm trying to educate more with people, as Dr. Garbely pointed out, is the substance-induced psychosis. Specifically with marijuana use, we're seeing more of this. So people often minimize that like marijuana is not harmful. It helps with all these things. A common justification I hear is it's safer than alcohol. But in regards to the psychosis piece, like we are seeing more substance-induced psychosis from the adolescents and the young adults, specifically with marijuana use. A lot of people have no idea that that can happen. So when you start telling people like, hey, this is something to consider when you're using regularly, there's kind of a disbelief, and they don't really realize that they're sort of at risk in that way. Another thing that we're seeing more is CHS, so cannabis hyperemesis syndrome. So this is something that happens to somebody that's a chronic marijuana user, where basically the prolonged marijuana use creates like huge digestive issues, and they have a lot of vomiting, dehydration, just abdominal pain and discomfort. I currently treat 3 clients that had that and have it. And they probably had, I would say probably 5 to 7 ER trips under their belt before it was diagnosed. So a lot of people don't even know that this is a diagnosis. So they're going to the ER with complaints that they're having these issues with their, GI tract or vomiting or whatever. They don't disclose that they're using. And then it repeats, rinse and repeats until a medical professional kind of gets on board with like, hey, there might be something that we need to look at with like the substance use. For clients that I've treated, when they get sober, the symptoms tend to improve, but they don't subside completely. So it's similar to psychosis in that way, like Dr. Garbely said, like Obviously, the first step when somebody's experiencing those things is to remove the substances, because that's just complicating everything. But once we do, we don't really know when and how it will get better. We can treat it with different methods, but it's not like as soon as you get sober, you don't have any of those symptoms anymore, whether it's psychosis or the CHS. As we get you sober, things may persist, and things may persist for like a long time. So it's just something to kind of be cautious of, especially if you have somebody that might be a prolonged cannabis user, that this is becoming more common. And it's because the potency is a lot higher. So we're just sort of in a different stage of things than we were 10, 20 years ago. I often use this with parents and providers. 6 years ago, when I was in adolescent care, substance use, again, the highest level of THC that I saw in somebody's system on a drug test from a lab was in the 800 range. I regularly now see over 1500. That is a regular occurrence for the kids that are admitting to my program. So that's more than double the THC amount that's in their system. I thought it was important to also kind of differentiate Delta 9 THC and Delta 8 THC, because I'm also seeing a lot of Delta 8 use. So marijuana is kind of tricky because there's a lot of different variants within marijuana, and some we know a lot about, some we don't know anything about. So what's going on is they're isolating different parts of marijuana and creating other products. That's like CBD as well. So Delta 9 is, when we talk about marijuana, medical marijuana, that's typically what people are using. Delta 8 THC, it has a similar molecule structure, but it's considered legal on the federal level because it's derived from the hemp plant instead of the marijuana. So it tends to have not as many psychoactive effects. It doesn't get people as high, basically, but it's readily available at a gas station down the street, wherever you're at right now. So a lot of kids, it's there and it's access, and they think it's safe because it's legal. And they also think they won't pop on a drug test. So a lot of kids that are trying to get sober from marijuana will then switch to Delta 8 because they're trying to get around like the drug test. So these were some statistics I found about Delta 8 specifically. And the first 7 months of 2021 alone, hospitalizations occurred in 18% of the 661 reported Delta 8 exposures. So once again, a lot of these kids are using it and they don't know the effects that it's going to have. And there can be a lot of adverse effects that land kids in the hospital. This is also not uncommon with edibles, especially at the adolescent level. I evaluated a kid this week, and this probably happens, I would say, at least bi-weekly. Kid ate an edible in school. A lot of times they'll eat an edible, adolescents, for ease of access. Once again, it comes in a little brownie or a gummy bear. Somebody's got some and they'll eat it. Some of my kids have never experienced a high on marijuana, period. And edible is the first introduction. And it has a really adverse side effect because it's sort of exactly like Dr. Garbely said, you light the fire, the bomb goes off later, right? And then the kids are, having psychotic symptoms or anxiety attacks in a school setting. And that's how they kind of get referred to me. So edibles, I'm seeing more edible use, and I'm seeing a lot of like first time users start with edibles. I also think it's like the packaging. It's like, oh, here's a gummy bear, right? And to an adolescent, they're like, oh, okay. Terminology, Dr. Garbely had mentioned that when you're talking to clients, if you hear a client say greening out, this is what they're talking about. So, the adolescents and the young adults basically call like an overdose on marijuana, right? So like they can't really, the symptoms of the high require like medical attention. They call it greening out. So it's like they just took too much. Something to like consider just with the Delta 8 specifically is there, and with the Delta 9 products, is there are risks for contamination. Specifically with the Delta 8, like they've been known to have like metal contaminants in it. So when we talk about sort of the impact on the lungs, right, a lot of these products have like pesticides and other things in it, and that's unknown. Obviously, they're not going to be labeled that they have that. So that's just another like contributing risk factor here to consider if somebody's using these products. I have this slide because somebody asked some questions prior to the training on medical marijuana in PA. The age to get a medical marijuana card in PA is 18. which is a little concerning just because everything we just told you about the risk of addiction, if you use before the age of 21. It's difficult too, because Dr. Garbely said, like I'm a harm reduction person. I'm not anti-marijuana, you know what I mean? But I tell people, like, the medical marijuana is not a medical product. There's no medical product that I can get from a doctor where I get a card and then I go decide my dosage and I go decide how often I want to use it. And especially with a lot of the adolescent and young adults, they're going to get large amounts. They're probably selling it to their friends, and then they're using it multiple times a day. So these were just some figures for the medical marijuana card program, NPA, that I got on, the government website. So, these are the active enrolled patients. There's currently a bill being proposed, NPA, that a doctor, if they determine that any medical condition can benefit from marijuana, that you can get a card. The current medical conditions accepted are listed on this slide. I'm not going to go through them, but if you are wondering sort of what PA uses as a framework for what, constitutes needing a medical card, it's there. However, I will tell you, the younger population knows that, like, I just need to go pay a doctor $250, tell them I have anxiety, and I can get my medical card. So for people that think it's a more thorough process, obviously it's dependent upon the physician, but for a lot of it, it's not. It's just like, I need to go tell them that I have this thing, and self-report that. And then I can give them whatever their cash fee is. And then I get a card. And like I said, then I get to go decide how much I want to do and when I want to do it. And for a developing brain, with the prefrontal cortex, the higher cognitive functioning, the decision-making, when that's not there, they're like, a lot of my kids that have had medical cards at one time, they're using every day, multiple times a day, and they're not managing symptoms. They're actually just making them worse, right? They're getting that rebound effect that Dr. Garbely talked about. Specifically with marijuana, we see a ton of rebound anxiety, see a ton of rebound depression. So it's just really, it's a tough thing right now, because, like, while I think, medical marijuana is needed and necessary for certain conditions, what we're seeing right now, in my opinion, is just not a medical model. And it's wreaking havoc specifically with the adolescents and the young adults, but with the older generations as well. Dr. Garbely went over this, but this is just, it's not the exact criteria in the DSM, but when we're distinguishing sort of like, is there a cannabis use disorder? Like, this is sort of the stuff that I'm always kind of looking for. I'm always looking for tolerance, right? Like, where did this start and where are you at now? Another common terminology that the kids will tell you, and this is how you can tell if, like, we're really talking about tolerance, they will often say, like, I'm taking a tea break. Well, if they say I took a tea break or I'm taking a tea break, that means they're taking a tolerance break. That means they know, and it's because of the carts, right? A lot of them smoke carts. Their tolerance has gotten so high that when they smoke, they don't even really feel high anymore. So that's a common thing with the younger populations that they're doing, and they readily talk about, like, I'm taking a tea break because it's just too much. The withdrawal effects that I typically see, I will say I underlined irritability, because, like, the irritability is, like, off the charts. So, like, with the marijuana use, specifically with the adolescents, it's like when they get sober, they tend to be very irritable, very edgy, very snippy. They also have a lot of sleep issues. That's another one that I've seen. We all know that, like, adolescents and young adults aren't, like, the best at practicing sleep hygiene anyways. So it's kind of complicated that even more. I will also say I see a lot of appetite issues. So there's a pretty high comorbidity with, like, eating disorders and substance use disorders. But specifically with marijuana, there's even more, because I get a lot of eating disorder primary people that then are smoking marijuana because it enhances their appetite. And so then when we get them off the marijuana, the eating disorder tends to pop up a little bit more, because they're not using that as sort of the stimulant to be able to eat. So that's something that I see quite a bit. Another thing is just realizing, like, is there, like, impaired social, occupational, recreational activities? A lot of the kids, the young adults, the adolescents I see, they've given up things that are important to them, right? They're not playing sports anymore. They don't have hobbies. They're isolated. They don't have friends that are into, like, positive activities. So that's always kind of like a key thing to me if I'm looking for somebody that's, like, maybe just, like, using, as opposed to, like, we're really talking about a true cannabis use disorder. In regards to working with the clients, like, substance use disorders, they tend to be a difficult population because they like to try everything the hard way. So motivational interviewing, motivational enhancement therapy, like Dr. Garbely said, it's kind of a way of like, I say like cozying up to the ambivalence about this process and really helping them explore like, why are they struggling so much with like making this change? Like, what is it doing for them? Right. That really works with like the adolescent and the young adult population to explore like the benefits of this. Like, what are you getting from this that it's so hard to walk away from? Because I also think somebody with like a true cannabis use disorder, as opposed to somebody that might just be using from time to time, they hold on to it tightly. Like giving it up is like a really difficult concept for them, right? And it's really hard because they don't want to, because it's serving a purpose. So in order to really work with somebody that's struggling with this, like really recognizing like what purpose is this serving, right? And how can we build that without a substance, and get them to kind of buy in like to the long-term gain rather than the instant gratification. So specifically with marijuana too, the ambivalence is like really high because the societal like information that's out there. I said this earlier, but like a common thing that I hear a lot is like marijuana is safer than alcohol. So it's often compared to that. It's a faulty comparison. Like that's what I always tell people. They're not the same thing. They're completely different. So I just don't try to fall into that trap, right? It's like apples and oranges. They're both fruits, but they're wildly different, right? Marijuana and alcohol, they're both substances, but they're wildly different. But that's something I commonly hear. And then Dr. Garbely had talked about this a lot with the families. I have a lot of parents that have their medical cards. So they will be sending their adolescent to treatment with me to get them to stop using marijuana while they're using marijuana every night in the home. So there's a lot of barriers there just because it's become this thing that has been deemed beneficial and helpful, and it's just kind of minimized in my opinion. And that's playing into all of that ambivalence, all of that resistance. Like you're basically kind of combating a bunch of misinformation. Learning to explore it and not judge it or not tell them like, hey, just stop this is kind of the way to get anywhere. You just really have to kind of help them build a discrepancy. Because like, if you just come in out the gate and you're just challenging their reality and telling them everything that they think is wrong and they need to just stop using, with an adolescent and a young adult, they're just going to kind of like go on their merry way and never want to talk to you again. So it's really just important to like express empathy, develop discrepancy, avoid argumentation, right? And just like roll with the resistance. And that's sort of like motivational interviewing. Those are like the quintessential things that people that use that do, so like a lot of the kids, like, it's like, they know they shouldn't be doing this, like the heart of the matter, like the ones that are using every day, if they're younger, they understand, it's not like a lack of intelligence. They understand that like using every day and probably the way they're using is problematic. But like I said, you have to explore why they feel like that's beneficial to them. And then you need to support self-efficacy. You need to really support the fact that like they can change, they can do something different, they can find other resources, they can create these relationships that Dr. Garbely talked about that can be so just monumental and really changing the trajectory of an adolescent or a young adult. I will say one of the barriers I have with some of that is like historically the 12-step fellowships, it's really hard to get an adolescent to go. It's really hard to get a young adult to go, but a little bit easier. The adolescents, it's tough. And then once again, this is something that I don't experience with the young adults, but I experience with the adolescents. Anytime I'm trying to get an adolescent to go to a 12-step fellowship, I tend to get pushback from the parents. The parents don't want them in that setting because they don't understand it. So they don't understand like what that process is. And they're like, okay, well, why would I send my kid to AA? They're not an alcoholic, you know what I mean? Or why would I send them to NA? They're just going to find other drugs there. So the amount of education that it takes just about some of the resources you're trying to get the kid to tap into is like also super necessary for the parents, specifically with an adolescent and the young adults, because they often live in the home. So it's sort of like if you're working with this population and you're not working with their, support system that they're living with, you can kind of really just like bang your head against the wall for like a long time, but also getting the family to the table is also hard too, right? Because they often want like the kid to get fixed or the young adult to get fixed. And they don't realize that like everything is like a contributing factor to like why we're here today. A lot of times with these clients, like if they're not truly ready to get sober, like I just work on decreasing harm. Like I gave an example of that today where I was talking to the college age student. I wouldn't even necessarily like diagnose him with a cannabis use disorder. He's just starting to like kind of explore using specifically with cannabis, but I really worked with him to like be like, can we not do carts? Can we not buy carts, right? Like, can we, and so to me, like a cart is a little bit higher risk because of the potency, because we don't know what it's in it than like the flower bud, right? That Dr. Garbely talked about the THC, it's usually like 10 to 30%, right? And typically like, you're not just going to find like all these harmful chemicals in it. And then with the carts, like people are also smoking them in ways that are super harmful, especially like the younger populations. Not to get like too in the weeds, but just like they often like will fray these wires to charge them. And they think it will hit harder because it burns differently. They're really just smoking metal though, but they don't know that. It's the wires are burning, the metal and the wires burning. So they think they're getting a deeper hit, but it's really like they're just smoking metal. So like on top of the carts, like access, potency, they're also using it in ways that are harmful and they think it's a better high, you know what I mean? So a lot of times if I'm trying to decrease harm with a client because they're not really there, I'll be like, okay, like can we not do carts, right? Also like in order to build discrepancy, like I've done all sort of creative things with clients where it's like, I've made contracts with clients where it's like, okay, what do you think healthy using looks like, right? Like if this was really going to benefit you, what would that look like? And we kind of make rules and guidelines as to what that looks like. And then I work with the client and eventually they'll cross off everything on that list. And I'll be like, okay, can we consider like true abstinence now, right? Like we did it your way. We did it the trial and error way. And you made the rules as to what healthy using would look like. And you didn't abide by the rules. So with motivational interviewing, it's a lot of kind of like creativity, right? It's like coming up with these like different ways of thinking about things to help the client get to the conclusion that they need to change. I can't force anybody to change. So I'm really trying to kind of like hold their hand. And like I said, meet them where they're at and get them there. But in order to do that in a clinical setting, like sometimes you just got to think outside the box. Also like, you know, with motivational interviewing and other types of therapy, like acceptance and commitment therapy, we also do like a lot of values work. So really kind of identifying like what the client cares about, and what's important to them in life, and then trying to show them how their behaviors and decisions kind of contradict those things. Right. So it's like, I can give you a prime example with substance use that always happens. It's like honesty. You talk to almost anybody anywhere and you ask them what they want out of a relationship with somebody they care about, and they'll say they want them to be honest with them. But when there's substance use in the picture, there's usually a lot of dishonesty. So a lot of times you can kind of use that contradiction to show them how the substance use might be harming their relationships, right? Because it's like contradicting the value of being honesty. Tried and true, like pro cons list, and then really focusing on strengths. So, like I will tell you, my adolescents and my young adults that I treat with marijuana use, they're really smart kids. They're really smart people. They might be disengaging from life. They might be like not attending school, like all of those things. They're super smart. And they've got a lot of skills that they just need to use in a more positive direction that they're using to continue their use. So it's really trying to get them to build that idea of like, okay, like if I just pivot here, I can use this thing that I've been using, right? Like this persistence or whatever it is, to really benefit my life in a positive way. Cognitive behavioral therapy, like, I mean, like you're going to hear that pretty much at every treatment center at IOP, anywhere that works with this population. I would say that's just because anybody that's getting into the trap of like a cannabis use disorder or using marijuana regularly, they've got some like really distorted thinking going on. That has to occur for it to continue to happen, right? So a lot of times if you can kind of sort of point out the specific distorted thinking, there can be a shift in perspective. I run an intensive outpatient program. I love running groups. I love running group therapy for this specific reason, because when you have a peer point out to another peer how they're justifying something or how they're minimizing something, it's usually way more helpful than if I do it. because that's somebody that's in the same position as them, that's probably doing the same things, and they can see it in their peer, even if they can't see it in themselves. So like in those group dynamics, it's a great way for people to like hold up mirrors, basically, and a great way for people to see themselves. And a lot of it is just sort of challenging the thought process that's leading to the behaviors and leading to the emotional dysregulation. The common ones we see is minimizing, rationalizing, and justifying. I think if you have an issue with cannabis, those three have to be present. I don't know anybody that doesn't have a problem and they haven't experienced that. They have to be minimizing sort of like what's going on in their life, right? Like when we looked at the criteria, sort of the impact that this is having, whether it's on their mental health, whether it's on their relationships, whether it's on their hobbies, or whether it's on like school or their work or something like that, in order for it to continue. They have to be rationalizing some things because they're making these decisions to kind of like choose something over something, right? And I always say this with like substance use issues, like it's not that these other things aren't important to them. It's not that their relationships aren't important to them. It's not that school is not important to them. It's just that their priorities are out of whack. So they're prioritizing the cannabis over everything else. It's not that these aren't important, right? And that's really impactful to note, especially with families, because families will get in this sort of like cycle of being like, well, they just don't care. Like, don't you see like their behaviors, their actions, they just don't care. That's not true, right? That's not true with substance use disorder. It's just that the priorities, substance, everything else. Once again, that's why like group therapy can be so helpful for this. It's also building relationships. A lot of people that really struggle with substance use disorders, they become super disconnected, whether it's disconnected from like self, others, or like meaning or purpose. There's just a disconnection there. So any way you can create connection, their chances like increase in them being able to like, you know, stop using the substance and build a quality life that they really enjoy. That's why the 12-step fellowships or the sober support groups are so vitally important. That's why organizations like Kim's be a part of the conversation is so important, because building connections at any part of their life will create safeguards. You like with the CBT, you can also connect the thought process to the behaviors and the emotional dysregulation. With a lot of my adolescent clients, they're really emotionally dysregulated right now. One of the other trends that I'm seeing is like the adolescent male has become pretty like aggressive in the household. And when the anger is triggered, they're doing a lot of like destructive things to like the home and becoming very threatening. That's a pretty common occurrence right now for an adolescent male that I get into the program. Once again, they know that that's like not good. But in the moment, it's like they feel like they have a lack of self-control just because they have no emotional regulation skills, because they've been using every time they feel some type of way. So like, if you can kind of connect like, hey, like we need to work on the emotional regulation because you've been masking that and using, and now you don't have that coping skill. We need to like really kind of develop this in order for you to like not continue punching holes in the wall. Generally, most adolescents can like get there. Like it doesn't have to be like rocket science to work with some of these clients. You just have to use the data at hand and help them understand, okay, like you need to connect this to the substance use, basically. They've not connected that in their mind. So you're trying to build the bridge. Part of that is also building the bridge with the families. So like I said, I get a lot of parents that will come to me for an evaluation with their kid, and all they'll want to talk to me about is like the anxiety and the depression, and they don't want to talk about the marijuana use, and the marijuana use will be like daily, multiple times a day. So it's taking a lot of education that like substance use is mental health. You know what I mean? Mental health is substance use. Like they're all intertwined. And getting the family kind of on board to see that. It's also helpful to like show them that like there are risk factors with substance use, and one of them is psychological conditions, right? So like if you have an underlying mental health disorder, you are more likely to have substance use issues. We know that. Also, you know, Joe put a pretty good side there, but like genetic predispositions, social environments, home environments. And like I said, this is tough right now because if you go into any high school anywhere, there's a kid that has a cart in the bathroom at some point during their day, right? A THC cartridge. So like the school environments, there's pretty heavy exposure there right now, specifically with marijuana. And it doesn't matter if it's public or private. You know, I talked to a parent the other day and they said, we're thinking about switching schools to a private school. And so like they won't be exposed to the substances, to the marijuana specifically. And I said, well, there's going to be marijuana in that school environment too. So it's really important to try to teach the kids how to navigate these situations because they're going to occur, which is why other environments such as the home environment can be so essential to making changes in order to support some safety there, some emotional safety. Personality traits are also a risk factor for substance use disorders. So, you get the kid that's like high risk taker, kind of adrenaline junkie, really impulsive, that kind of stuff, thrill seeker. Or if you get the kid that's kind of like the isolated, the retreater, the introvert. So it's not sort of one thing. It's just knowing that like substances, specifically marijuana, might appeal more to somebody that has certain personality traits. Cause like I said previously, it might do something for them. Often when we're talking about somebody that has marijuana use disorder, it's doing something for them. They wouldn't keep doing it if it wasn't. Families often struggle with the same misinformation that clients do. So like, this is not irregular thing. I've had parents that will get a medical marijuana card for their kid when they turn 18, thinking that like, okay, they're just not using street weed, so maybe this will help. And it's not because they're bad parents. They're just misinformed. Like they're not educated. So they think this is better than this. Or I'll have parents say, well, like, they're using marijuana for their anxiety and I don't want them to have to like be prescribed like a narcotic, you know what I mean? Or like benzodiazepines, or I don't want them to take psychotropic meds or whatever it is. So it's just misinformation. And so education is really key, especially if you're working with the families along with the clients. So I just never assume that people know. You know what I mean? And as a clinician, I have a plethora of resources, whether it's podcasts, whether it's books, whether it's articles that I can send a parent to back up sort of what I'm saying, because that really helps, because it's like, okay, they're not only hearing it from me, they're getting it from this other source as well. Like I said, families often enable unknowingly and give permission for continued use due to minimizing the impact of substance use because it's marijuana. This is not uncommon. With the adults, as Dr. Garbely said, like you'll see families, like even though we tell him, hey, like complete abstinence is probably the best way. That's like what everybody kind of agrees upon. They'll be like, well, they were using opiates and marijuana is like not as bad and won't kill them. So it's just, there's so much misinformation going on. And with the adolescents, like they truly think it's like okay for them to use, even though like pretty much everything that I've read, and maybe Dr. Garbely could, like, he seems to have a little bit more of the research knowledge, but like everything that I've read is it's not good for the adolescent population or the young adult population. Like, it's just not. Like, regular use will basically wreak havoc on their mental health. That's like, I talked about it earlier, considering the alcohol versus marijuana comparison. Like, I just don't get into that debate. I just tell them it's a faulty comparison. One of the resources me and Kim have talked about, but there's a podcast by Dr. Huberman. He did a great one on marijuana. If you want more additional resources, and Kim has that on the website. But basically he talks about all this stuff about marijuana, and then he gets to the end and he's like, none of this is true for the developing brain though. So like none of this stuff is talking to people that, are under the age of 25, which is the typical age that we use. But as Dr. Garbely said, women are a little bit younger, men are a little bit older. And then something that's just key if you're working with the family is consider how substance use is modeled in the home, and don't ever make assumptions. So like I have parents that regularly use marijuana that like you wouldn't think that they would be the ones that would, so it's just, I always explore that with the parents or with whoever's in the home environment of like, what's your relationships with substances? Because like kids, young adults, adolescents, they're much more interested in what you do rather than what you say. So like if you're telling them to get sober, but every night when you come home from work, you're smoking weed or you're drinking a glass of wine, their messaging is, okay, well, it relieves stress, so it's okay for me to do it after school. You know what I mean? And that's sort of like some of these ideas that get planted in their head unknowingly, even if the parent's not saying that. So if you're working with the families, it's just paramount that you also explore their relationship with drugs and alcohol. So yeah, that's all I got. I'm going to stop sharing now. And then Kim, I don't know if you're going to open it up for questions.
Absolutely. Great job, Lizzy. Thank you. That was fantastic. between the two of you, I think we've covered quite a lot. I have a few questions. I think there are some others, but I want to hear from all of you. So I know so many of you are really on the front lines with this. So please jump in and share what you're experiencing and how we can help you to navigate this. And don't forget to unmute yourself if you want to share.
We did just get a question in the chat for either of you, Lizzy or Dr. Joe. From a neurobiological perspective, how does marijuana use increase mental health concerns, either anxiety or depression in adolescent and young adult users?
I could take that, Lizzy, if you don't mind. Okay. As I said before, that the brain is not fully developed until somewhere in the mid-20s, right? And in that process of development, the structure that's most important is the prefrontal cortex. That's where higher executive functioning comes, good reasoning, sound judgment. It's also where emotion is really regulated. And if you somehow disturb that process, you will have an increase in the possibility of anxiety disorders, depressive disorders, and things of that sort. There was a study, I did not include it, but there was a study that was done that NIDA and SAMHSA often quote, which shows that marijuana use in young adults and adolescents actually increases likelihood of all psychiatric maladies and worsens existing psychiatric maladies across the board. So it's a vulnerable time as our brain develops. There is plasticity that occurs in especially in the younger brain. However, if you disturb that process of maturation, you're going to increase the likelihood of not only addiction, but mental health disorders.
Dr. Garbely, while you're unmuted, if you could address, and I know this is something that you've given lectures on, opioid use disorder is one of the 23 conditions that are listed to qualify someone for a medical marijuana card. Can you address
yeah. So I had something to do with that list, as it turns out. The state senators and representatives came to Karen when I was there early in my tenure there to talk about how to roll this out. And we gave our thoughts on that and really how to limit the disorders that marijuana can treat from a medicinal point of view. And they have expanded that. They did start with that list and then they expanded it. Opioid use disorder specifically was placed on there to study marijuana. So the reason that they put it on there was in an effort to do research on marijuana in opioid use disorder. There's a lot of money now in opioid use disorder funding, or there's a lot of funding for it because of the crisis. We're losing a generation, rightfully so. But they tapped into that. Dr. Levine, if you remember Dr. Rachel Levine, she actually called me right after she added that just to discuss it with me. Because the reasons were backwards. That in order to study medical marijuana or marijuana in general, they had to put certain conditions on the list, and that was one of them, opioid use disorder. I think the one thing we have to understand is there's not a lot of research on marijuana. One state, Mississippi, has been the only state allowed to grow marijuana for research purposes. That's been opened up recently by the DEA, who stubbornly said no to repurposing and rescheduling marijuana. It's a Schedule I. It has no medicinal effects according to the federal government. And there was a big push to change that, and DEA resisted, thank God. But they said, we will revisit this with research. And they opened up research, which is happening now, but you have to have a connection to a medical school to do the research.
And even studies overseas and things are not looking at the really high potency, and they're certainly not looking at the developing brain.
Correct. Exactly.
All right. Wynn, I see your hand up. Go ahead.
Oh, can you hear me? First of all, thank you both. This has been fantastic. And Lizzy, it's good to see your face. um, so my question, and Lizzy, you'll understand this. Let's say you're dealing with a teenager. I worked at rehab after work and facilitated an adult IOP for 10 years. I would fill in for the adolescent IOP when, they were in between therapists or somebody quit or relapsed or did something else, whatever. And the kids that get clean are just absolutely amazing. I mean, it's just incredible. The parents, I agree, Lizzy, that it's much harder to deal with the parents. I'll never forget. This one boy said, I took my big book and I left it on my mom's computer, and I wanted to cry. They're just incredible. So my question is about when we get an adult, when I would get an adult in, do an evaluation, it was like, you need IOP. You need to go to meetings, whether you want to go or not, you're going. So how do you, let's say, make the decision? And Lizzy, you know what I'm talking about. A kid that, they're, and I was thankful to hear that you have this group full of kids that when I was at rehab after school, it was a lot of kids that were heroin addicts, which was why I would go to sleep thinking about them and wake up thinking about them. And I just could not take the stress because the parents were like, I'm not sending her inpatient again. And it made me want to jump out of my skin. But what do you do with the kid that gets high once a month, isn't motivated to get clean? The parents are punishing. And I'm like, but why does this kid want to get high? You know what I mean? You know what I'm asking. It's such a tough thing. They're kids. Their frontal lobe isn't online yet. It's just so hard.
This is sort of like, especially with the adolescent population, it's like a different game. Like, if you want my opinion, you know what I mean? Then
It's like planting seeds that might grow later.
Yeah. So a lot of times you're just trying to reduce harm, right? While you educate, while you help them explore, because a lot of them don't have the insight-oriented process yet that you need them to see for the underlying factors. Or sometimes they know and they just don't care. You know what I mean? So hypothetically, if a kid has gone from using every day to maybe using once a month, to me, that's a victory. You know what I mean? Obviously with the goal of complete abstinence at some point, but if we're decreasing use and the client's quality of life has improved, and the parents have put in appropriate safeguards and there is accountability, my thing is it won't spiral into a crisis as quickly. When there's not safeguards in place, accountability, drug testing, stuff like that, it can spiral really quickly and nobody knows. So it's just a little bit different because the kids that want total abstinence, I've had 2 in the last 4 years, to give you guys an idea. So you know what I mean? And I have one that has over 400 days and one that's getting 1 year and 2 weeks. Both were marijuana. But a lot of them, it doesn't mean there hasn't been success. It just means we're reducing harm, right? And we're reducing harm and building discrepancy and exploring when things happen. So if and when they're ready, we can capitalize when there's an opening.
Do you think it's more because I'm thinking of the teenagers that were successful in rehab after school seem to be the opiate addicted kids that knew I'm going to die. It's abstinence, or it's harder with marijuana, like you said, because of the misinformation.
Yeah, absolutely. You know what I mean? They don't see it as sort of this live or die kind of thing, even though a lot of times, in my opinion, with the opiate use disorder and the marijuana use disorder, the emotional dysregulation is the same. So, and the impact on the quality of life is the same, but the risk factor in their head is not as great. So you're not dealing with, you don't have that external motivator that might be in place with somebody that's using opiates and the fentanyl stuff that's going on, right? There's an idea that maybe I'll get a laced cart, but it's also, you know, the addict mentality of like, that would never happen to me though. You know what I mean?
Right. Okay. Thank you so much. I want all of the information to send to people, all the podcasts, please. Thanks again.
Dr. Garbely, did you have any thoughts you wanted to share about that?
I thought Lizzy really summed it up excellently. I think harm reduction is something we have to embrace. You know, we've lived so far in the treatment world, abstinence only. And then, you know, what happens is you lose patients that way. I think it's she said it beautifully, a process in which we look for an opening where we can get them to that point of understanding that abstinence will be a better way to live their life. But they, you know, right away, that doesn't often happen. So we can't, to a hammer, everything's a nail. We have to stop doing that. And that's,
It's
you know, something,
anathema.
yeah.
Harm
No, I
reduction is
agree.
anathema.
Yeah, well, that's true. And you hear that, and there's a lot of pushback around that. But the truth is, anyone who's in the treatment business understands you have to meet the client where they're at and walk them through a process.
Yes.
Here's a question in the chat. How can you explain, what are the words we can use with a teen who thinks that cannabis is helping their anxiety, but it really isn't? We know it clinically, but how do we explain that to a young person?
Is that going to be me again?
I'm old, so I'll just say, anytime they say young person, I'm thinking you, Lizzy.
Oh, that's so nice. I'm glad I got it today. So with I mean, this is not an uncommon situation, right? So that's where I'm trying to tell you guys, like, it's doing something for them. So you need to explore what it's doing for them and then try to get them to find and use other things for the anxiety. So like, if they think it's helping the anxiety, like, we know it's not, but you have to connect the bridge for them. So oftentimes with a client that like thinks it's helping the anxiety, I'll be like, look, like it's a short-term relief. So like in the immediate, when you're high, it probably feels better, right? But long-term, the anxiety is worsening. So I always kind of use the idea of like, okay, so you have this thing bubbling like under the surface always, right? And eventually it's going to boil over, but you don't really notice how much it's boiling because you keep kind of like, you know, using and calming it down a little bit and using, but eventually like it's going to boil over. And I often tell them, like, if they stop using, like your anxiety is going to get worse. So I don't paint this like pretty picture for them. I tell them like, look, like in the immediate, like I'm going to ask you to stop using and the anxiety is going to get worse, but then we can develop the skills that you don't need the marijuana and you can actually manage the anxiety. And over time, if you do that, like it will improve. So it's just kind of like getting on their level or using a metaphor that maybe they'll relate to, and also letting them know, like, usually if they're using it for like a mental health relief, like self-medicating, like if you ask them to step away from it, you're asking them to step away from their main coping skill. So like it will get worse in the short term, but in the long term, it will get better.
And I don't know if this analogy works for a teen necessarily, but I often think about the fact that, you know, opioids do not, they certainly make you feel less pain on the acute stages, right? Like initially, if you feel less pain, it's not treating the pain. And in fact, if you continue to use opioids in excessive use, you're going to get hyperalgesia, you're going to have, you know, increased pain. And it seems very similar to me that with anxiety, we're not actually dealing with what are the underlying causes. Yeah, a shot of vodka helps tremendously with anxiety, but it's not sustainable, it's not treating anything, and it's not going to help in the long run.
I'll often ask kids to, oh, sorry, Dr. Garbely.
No, go ahead.
I'll often ask kids to tell me about like the other kids in their school too, because like every kid knows a kid that they would deem like they have a drug problem. Do you know what I mean? So I'll like explore sort of their peer dynamics as well and sort of the labels they've placed on other people and why. Like, why does that person have a problem, but you're just using it to treat anxiety? So I'll kind of use the dynamics and like the peer groups as well to piece some of this out and really kind of explore sort of like how they're comparing themselves rather than how they're relating.
Very well said. And I love the hyperalgesia reference with opioids. That's something we deal with chronic pain patients all the time. Simply taking them off the opioids that they've been abusing, their pain actually gets better. And I think that's true with anxiolytics, in this case, THC, that it may be helpful in the short run, over time. But as they increase the potency and increase the amount that they're using, then that hyperalgesia thing comes into play, and anxiogenesis then becomes the issue. So anxiolysis, which is what they're looking for, gives way to anxiogenesis, just like with pain medications.
Thank you very much, both of you. Great responses. Are you having issues getting people, Dr. Garbely, this will be for you, using THC into inpatient treatment, or actually it's for both of you, Lizzy, I'm sure you have folks you would love to get into inpatient treatment, and are insurance providers more the problem with this, or is it the treatment providers?
So the answer is yes. To the first part of your question, yeah, it is difficult if someone simply has a cannabis use disorder. We don't see a lot of that here, but then again, we're on the receiving end, if you will. And we see more polysubstance. So somebody where cannabis use disorder is part of their picture, but not the primary. Oftentimes opioids or maybe benzodiazepine use, whatever it may be, is the reason that the insurance company grants that they can come in to this highest really level of care, where we are at Brookdale. So Lizzy, I don't know if you've had trouble getting people into this level of care.
It's different for adolescents than if you're 18 and over. So 18 and over, if you're primary marijuana and that's all you got, I think there's some barriers there with the insurance companies. If you're an adolescent, no barriers. I would say like probably a majority of kids that are in residential facilities might have a primary cannabis use disorder diagnosis. I think a lot of that is too with the younger populations, like most of them are dual diagnosis. So the acuity of the mental health and the substance use, they're often like kind of fighting. I've talked to providers where we're like, well, I don't really know which one's primary because they're both bad. You know what I mean? So a lot of times like adolescent providers are licensed for both. So it's just a little bit of a different game. Like a lot of adult facilities, it's like their primary substance use, their primary mental health. A lot of the adolescent providers are licensed for both. So they can kind of work it either way with the insurance company to get the client the treatment that they'll need.
Here's a question that we hear a lot about too. How much influence does the marketing, I think that we're referring to CBT, sorry. Yep. No, not CBT, CDB. And hemp products have in teens justifying the safety. So hemp is now legal, is legal through the Farm Bill. So that's all we're seeing, the THC-8 and all that sort of stuff is coming through hemp. And CBD is obviously something that we're seeing a lot of in the legal market. So how much is that impacting the safety of using cannabis?
So I could start, Lizzy, if you want to jump in specifically around adolescence, but my theme in my talk was had to do a lot with messaging, right? Marketing in that regard. So looking at marijuana or CBD as helpful and medicinal has made people believe that it's safe. And CBD, as I mentioned before, certainly the study that was done by the FAA, there was no products out there that they found that didn't have THC in it. So, and the regulation of that, it's just not there. While states can say you can only have this much THC in CBD, good luck finding somebody that's regulating that. It's just not happening, enforcing it rather. And that's what we're seeing too often. Physicians go through this all the time as well, where they're using products that they're buying on the internet, and then they get a spot urine drug screen for whatever reason, and it looks like they're impaired and their career is in jeopardy. And they really did just simply try to use CBD. Surgeons, over hunched over. They oftentimes get a lot of orthopedic complaints. And they use CBD, but then, their career is jeopardized as a result of these companies not being disciplined in their product.
I would say the reverse is true for me. I get kids that admit to the IOP and then we'll start using CBD products because you tell them like they can't use the THC products. And so then they'll and their parents will buy them often CBD products for their anxiety, because that's like one of the things that it's touted to help. And then they'll fail a drug test, but be telling me they didn't smoke marijuana, and it's really the CBD. So that is something that I just think is helpful to know with the CBD. It's like you can fail drug tests, and it often does happen. So I wouldn't say for me, it's more access to THC. It's just sort of like the next thing that happens in my process when you try to get a kid sober.
Makes sense. Thank you both. So if someone, a young person has pain, they're claiming that they have chronic pain and they have, or physical issues, I guess, and they even have a medical marijuana card, but they may not be adhering to the dosage, whatever that might be, and can't, in other words, can't give frequency or the amount used. What kind of therapeutic support is there for that young person?
If I can just jump in, I gave a talk on Capitol Hill with Bertha Madras, who's the head of research at Harvard, and she looked at all the pain studies that have ever been done and the utility of marijuana to relieve pain. The only studies that showed any promise, any separation from placebo, were neuropathic pain studies. So we're ubiquitously painting with one brush on a very intricate canvas here, and that's a real problem. And so we're saying any pain is relieved by marijuana, when studies have shown other types of pain, there is no separation from placebo. There is no pain relief. So we're exposing people with no efficacy to a very dangerous substance. Lizzy, you want to give the young person's?
I kind of like this. We should
Again, I'm old.
I was just going to say, from a therapeutic component, like my frame of view, if I had a client where this was going on, is I would kind of treat them through the lens that I treat a lot of people that have a prescription for a narcotic from a doctor and they're not using it the way that it should, or it's misprescribed, in my opinion, which is always tricky because I am not a doctor. And I'm kind of going to go up against a physician, but there's a lot of prescription things like benzodiazepines, opiates that are often misprescribed, and people will come to me because it's not working, but they don't know that like the substance use is an issue. So once again, it's kind of that motivational interviewing. It's trying to get them to see that like, hey, while this might be something that like a medical professional gave you, it's not really working for what you need to resolve, and sort of just working to build that discrepancy. So like for me, it's like, when I see somebody with a medical marijuana card and I think it's like creating a hindrance to like their mental health, or it's creating like an impact on the quality of their life, I'm looking at it like it's a misused prescription, which happens with every substance that's prescribed.
Right. It's so many. I mean, I'm not a therapist, but I'm with families constantly who are struggling with this. And I can't believe how the demographic has changed and that the parents are presenting with really young kids. You know, we've got 13, 14, 15-year-old kids that they're struggling with cannabis use. How do you handle the concept of abstinence with a young person? I mean, is it delay until you're at least 21? Is it, because that's such a tough concept. I mean, obviously no one should be using it at those tender ages, but you know, kind of the notion of, oh, you've got to start going to AA meetings for the rest of your life now. You know, how do you approach this clinically for such a young person?
I guess this one's me too, Dr.
Yeah,
anytime it's young, you're
okay.
in.
Okay.
And you're with so many young people, Lizzy. You're
yeah. I mean, it's the meeting them where they're at. Like, they don't want to hear your sobriety chat. You know what I mean? Like, they don't want to hear the abstinent-based model, which is cool. So I just talk to them on their level with where they're at. And in my frame of mind, what I see is like, listen, if we can get any sense of sobriety, like that's a win for the developing brain. Right? Like if we can get these periods where they're not using, like that's a win. So like, to me, it's just a different idea of like, most of the kids I meet are not going to be sober for the rest of their life, but I can start planting seeds and maybe I can put different people into their life or hobbies or interest, or develop some of the home environment and repair those fractures in the relationships. So things are just more safe, right? Or like the kid might not be as at risk, and the parents may stop enabling. So it's just, I work with another therapist here, Lex Remillard. A lot of people know him, but we talk often about the boomerang effect with adolescents. So it's like you'll treat them when they're 13, 14, 15. You'll develop this rapport. You'll hold boundaries. You'll give them all this information. And then 5 years down the line, they find you. And they're like, okay, I'm ready now. Like, I remember some of that stuff you said, and I'm ready. So it's just a lot of times with the adolescents, you got to know you're playing the long game, but it's still not pointless, right? Just because you might not be getting the result you want doesn't mean it's pointless. And anything you can do to kind of like get them to think about things differently or change some behaviors, even if it's for a short period of time, like that's a success.
Right. Very good. I think we'll take this one last question. So for someone who uses CBD pens, how can you explain that this is still harmful to them? I've many people say, well, it's just CBD. It doesn't get me high. It's not harmful.
So again, I'll just, sorry to continue to beat a dead horse, but CBD is not just CBD. There is THC in that. And if you use enough of it, you're going to get enough THC to feel differently. And with that difference of feeling, you may seek it out and use more and more and more and more. It's not something that we know, scientifically speaking, to be the end all be all when it comes to pain or whatever ails you, but it's been sold as that. So it's been sold as a panacea that treats everything, and without any studies behind that. This is, in my lifetime, I've never seen this before, where we just grab this botanical and say that it fixes everything that ails you, when the studies clearly say it doesn't. I mean, there are things it does, but the science is out the window. I mean, this is a huge marketing campaign. It's been incredibly successful. It's hatched a multi-billion-dollar business, and that was the whole intention from the beginning. And here we are, with a bit of a mess on our hands, trying to put the horse back in the barn.
As one of our other favorite presenters, Ben Court, talks about, there aren't socks that say Lipitor on them. There aren't dish towels that
Sure.
show off that I'm using, whatever, kind of other medications. Yeah, it's such a misconception out there that this is medicine. It's such a shame that this is happening this way. And so much of this is driven by the desire for revenue in the state. And my goodness, the behavioral health implications are just very intense.
Mm-hmm.
I cannot thank you both enough. This has been fantastic. Thank you all for being with us and hanging in here for a couple of hours on a Friday. So if I have everything in the chat that you need to get your credits for that, to complete that evaluation. We also have a survey that the link is in the chat. Please take that. We really appreciate your feedback. And the follow-up page will have this recording. It already has the 2 slide decks, and I will link in Dr. Huberman's podcast that Lizzy mentioned. And Lizzy, Dr. Garbely, or anybody, if you have other resources that you think would be helpful, I'll get those loaded on that page as well. Thank you very, very much, everyone, and especially Dr. Garbely and Lizzy Lopez.
Thank you, everyone.
And one other thing, if you join from a phone,
Yeah.
we don't know who you are. So if you could email Kim or myself, our contact information, will be on our website at conversation.zone. We'll be able to make sure you get your credits as well.
Right. If you're not looking for credits, you don't have to email us. But if you want credits, please email us on the phone. Thank you again, everyone. Have a great weekend. Go Birds.
Go Birds.
Go Birds.